Okay, so it's just gone 12:02, and I see we've got over 30 participants now. Uh, Hello, everyone. It's my pleasure to introduce today the topic for the PAL session, which is going to be lab operations and co-management model. I just want to take the time to acknowledge that I'm from the broadcasting from the traditional and unceded territories of the Coast Salish peoples, including the Musqueam, Tsleil-Waututh, and Squamish nations. Obviously, this is being broadcast across the province, so you can recognize the territories that you're in. This actually is an excellent session from a topic perspective because you may be aware that I've taken over recently as the regional and department head for Vancouver Coastal Health Department of Pathology and Lab Medicine. And this is a very important topic because it's to discuss the lab operations and co-management model. And I think it's very important for us to understand the importance of operations and ensure that we are identifying what is our area of responsibility and what is their area of responsibility, working cooperatively and collaboratively and not stepping on their toes, etc. So I'm really, really pleased that this is being presented. I'd like to introduce the three speakers. Brenda Jackson is a seasoned leader in clinical laboratory operations with extensive experience across public and private healthcare systems. As Senior Executive Director of Clinical Operations for PLMS, she drives strategic objectives and oversees planning, integration, and evaluation of clinical lab services in collaboration with the regional health authorities and private partners. Brenda also has responsibility for consolidated laboratory operations staff for Vancouver Coastal Health, PH, FH. What does FH stand for, Brenda?
Fraser Health.
Fraser Health and PHSA laboratories. Previously, Brenda managed the lab medicine portfolio for the Diagnostic Accreditation Program and served as technical director at Life Labs, as well as lab director at BC Biomedical Laboratories. I'd also like to introduce, so thank you for coming, Brenda. I'd also like to introduce Jennifer Minchinton. Minchinton, is that correct, Brenda? Jen, sorry. Lab Operations Manager for Vancouver Coastal Health with VGH and Seashell Labs under her portfolio. Prior to Vancouver Coastal Health, she spent 15 years at Life Labs in their microbiology department before becoming the supervisor of the special chemistry area. And finally, Luca Rizzetto, the site supervisor for the lab at Vancouver General Hospital. He's worked as a medical lab technologist for over 20 years in various hospitals with Vancouver Coastal Health, Fraser Health, and Interior Health Authorities. So again, the three of you, Jen, Brenda, Luca, thank you very much for coming and agreeing to talk. Over to you.
Thanks. Thanks so much, Mike. I am sharing my screen, so I will miss if there's any questions. So feel free to speak up at any time. So today we're going to explore this dyadic leadership model and its application in laboratory medicine. So this approach is being thought of as new and transformational in healthcare because of its fostering collaboration between clinical and operations leaders. But I'm going to tell you, in laboratory medicine, and I've been doing this quite a while, it is actually a foundational part of our structure within laboratory medicine. And so just a quick kind of roadmap of where we're going to go today. So I'm going to introduce the concept of dyadic leadership. We're going to go to Luca, who's going to look at it through his lens at Vancouver Coastal Health. We're going to do a bit of a case study with Jen on the GAD-65 implementation at VGH and how medical and operational work together. And then I'm also going to bring in a bit of a provincial lens on how that dyad even works at a provincial level for policy, strategy, and operational needs at a provincial level. So just to begin, what is the dyadic model? So the dyadic model, or a dyad, is a medical leader for us with an operational leader. And it blends clinical expertise with administrative skills to create that unified leadership approach. In labs, this ensures that patient care priorities always are aligning with operational realities. And right now, that's a huge fiscal reality, HHR reality, and our compliance requirements. So why does dyadic leadership matter? Because it really improves patient care and work efficiencies. It builds that, I'm saying, organizational trust and enhances communication and transparency. When you look at that, the image there, traditional models, a physician and the administrative leader in an organization usually report up, and it can be to different VPs, especially in our healthcare organizations in this province. But in a collaborative dyad, you increase the scope of influence. When you're working together, you now have a collaborative scope of influence where you can influence your health organization. So it supports the collaborations. We've got leaders work at the top of their skill set and therefore maximizing return on time and effort, which can reduce burnout. And we know that's happening within healthcare. And it also leverages the complementary strengths. The partnerships really learn from each other. So ultimately, it creates a culture of collaboration and excellence. And I can tell you that when our staff see that leadership dyad working well together, they can really get behind change when the dyad is working as a team. So why dyads in laboratory medicine? And I want to say that laboratory medicine was one of the first to ever adopt this dyad. And very first one is regulatory responsibility. So our accreditation standards, which in this province are diagnostic accreditation program, are ISO 15189. And these standards require the dyad. It discusses the dyadic leadership model and that it must be held at a regional level and also at site level. So we have that responsibility to have the dyad. It also really works well in lab medicine because we balance clinical quality with that operational performance and increasing efficiency. Again, it breaks down silos. So the dyad structure eliminates the traditional barriers. As I showed in the slide before, we increase our scope of influence by having this structure. So kind of looking at the core benefits of dyadic leadership, unified vision and strategic goals. So we are creating that alignment between clinical priorities and organizational objectives, and working together, we are ensuring that the decision supports both patient care and institutional sustainability. Right? We have complementary perspectives driving better decisions. So our medical directors bring us clinical expertise, the patient-centered thinking, and the operational leaders contribute their financial acumen and process optimization. So again, working together to form these really comprehensive solutions. The communication and trust. When the communication and trust starts at the leadership level, it invariably falls down and our staff can feel it. So also elevated quality, safety, and compliance, working together for all the regulatory needs that we must meet in accreditation. It shows great effectiveness in our laboratory operations and our delivery of service. So and we're going to get to some of these, dyadic leadership in action. So how does it work in laboratory settings? Well, when we're implementing new diagnostic technology, medical director is there to evaluate clinical utility, validity, and the operational leader now brings in the financial impact, the workflow integration training requirements. And by marrying these two together, we get that successful adoption. Things like staff shortages. By working operations and medical, we can prioritize what are essential services while always maintaining standards and always looking out for our employees' well-being. Again, it's a regulatory imperative here in BC, but we get to respond to audit. We look at new regulations together. You know, what this is, all this practical applications is how we work together with a really unified front for our staff. And now I'm going to quickly pass it over to Luca and Jen, and they're going to deal with their experiences at VGH. So I will stop sharing and pass it over to Luca and Jen.
Okay. Thank you. Thank you, Brenda. Dr. Hamill, thank you for the introduction, and Dr. Smith, thank you for asking me to actually co-present to the group. I am not a polished speaker as Brenda is, so I actually pre-recorded my presentation. So I'm just going to play that now. Hopefully you can hear it. Please turn up your volume as high as you can in the event that it does come across a little bit quietly.
Good morning, everyone. My name is Luca Rizzetto, and I will be presenting a short slide deck entitled Aligning Clinical Excellence with Operational Efficiency as part of today's presentation. At Vancouver Coastal Health, laboratory services are managed through two complementary leadership arms. On the medical side, we have pathologists and medical directors who provide clinical oversight. They ensure test validation, interpret results, and set policies to maintain patient safety. On the operations side, site managers and regional operations directors handle the day-to-day running of the labs, staffing, workflow, equipment, IT systems, and budgets. This ensures our labs operate efficiently and reliably. Provincially, we are supported by the PLMS
Luca,
Did I kill the
sound?
audio there?
Yeah.
Oh,
Hey, I
sorry.
can't hear anything. Brenda, can you hear anything?
I think it.
Yeah.
You know what? I think I might have somehow
It interrupted
paused.
the audio.
I might have paused it. Sorry. I'm going to resume. Sorry about that. Nothing.
Not yet.
Yeah.
The screen is paused. Oh, great. Now I don't know how to restart this thing though. Resume.
Maybe if you stop share and share again from the current slide, it'll just start from the beginning of this current slide.
Okay. Sorry, guys. Okay. Still nothing.
Still nothing.
Jeez. No. Okay, hang on. Try again. Sorry.
It's okay, Luca. It's not a Zoom meeting without some technical challenges.
Well, I just don't know what I did to stop it.
I swear I didn't do anything.
Luca, besides
Yeah.
share, you're on pause.
Yeah, but like when I hit resume, it's not seeming to do anything here.
Below in the little green bar, there is a counter like 3121. Could you click
Yeah.
that little down arrow? I'm curious what that says. If you just move your cursor a little bit down from the pause.
From the pause here,
Yeah. I can't see your cursor moving.
there's nothing there. You know what? I mean, I can just I mean, if you bear with me, I can just restart this thing.
Sure.
Yeah,
Okay.
let's try that.
That works.
PHSA system. Oh, here we go. Got it.
standardized practices and ensures access to reference testing. The key takeaway is that both arms must work together. Clinical guidance without operational support cannot be implemented, and operations without clinical input could compromise patient safety. An example of this collaboration would be when introducing a new urgent test, the medical team defines clinical need while operations ensures we have staff, instruments, and workflow to deliver results on time. Lab operations encompass several core functions. First, diagnostic services, which include chemistry, microbiology, hematology, pathology, transfusion medicine, and specialized testing, all critical for patient care. Second, operational delivery. This covers everything from specimen collection, processing, testing, reporting, and IT integration to logistics like sample transport and workflow optimization. Third, quality and safety. QA, QC programs, accreditation, incident monitoring, and continuous improvements are key to preventing errors and maintaining high standards. Finally, workforce and training. Ensuring we have the right people, properly trained, with competencies maintained for all lab activities. Each of these areas requires close collaboration between medical and operational leadership to ensure safe and efficient services. An example of these core functions of laboratory operations would be a spike in sample rejection rates would trigger a joint review, possibly leading to workflow improvements and additional staff training to prevent reoccurrence. VCH Labs uses a co-management model, meaning both medical and operational leaders share responsibility for decision-making, but each focuses on their domain of expertise. For example, test menu and validation. Medical leadership ensures clinical necessity, while operations assesses feasibility and cost. Equipment and IT. Medical focuses on clinical performance, while operations handles procurement, service, and integration with lab information systems. Quality. Medical monitors outcomes. Operations ensures process control and compliance. Staffing. Medical supervises clinical roles. Operations plans schedules and budgets. The goal is to align clinical priorities with operational capabilities, ensuring safe, timely, and efficient service. A practical example is introducing a new urgent test. Clinical leadership defines the need. Operations ensure staffing, supplies, and workflow adjustments are in place. Effective governance is essential for the co-management model. At the site level, laboratory leadership teams coordinate daily operations and clinical oversight. Regionally, committees ensure standardization and compliance with provincial regulations. Joint medical operations governance meetings provide a structured forum to make decisions about resources, test implementation, and quality initiatives. Processes include monthly co-led meetings, monitoring shared KPIs like turnaround times, QC compliance, and incident trends, and documenting all decisions for clarity and transparency. The key to success is regular, structured communication, clear roles, and a collaborative culture, which allows us to respond quickly to challenges and keep patient care at the center of all decisions. As an example, when our hematology instrument went offline a few years ago, governance meetings allowed rapid triage. Medical prioritized urgent tests, operations redeployed staff and resources to UBC Hospital Lab, minimizing service disruptions. The benefits of this co-management model are significant. Integrated decision-making, improved patient safety, operational efficiency, and stronger engagement across teams. However, there are challenges. Competing priorities between clinical needs and operational capacity, potential communication silos, and unclear roles can create confusion. To address these, we recommend 1. Maintain monthly joint meetings with clear agendas. 2. Use shared KPIs and dashboards for real-time performance monitoring. 3. Clearly document decision authority between medical and operational leaders. 4. Engage provincial partners to align with PLMS, PHSA standards. 5. Foster a one lab team culture that emphasizes collaboration and shared goals. By proactively managing these areas, we can ensure the co-management model delivers on its promise: safe, efficient, patient-centered laboratory services. Thank you.
Okay, over to you, Jen.
Hey, see if I can get the correct thing. Can you see my screen? Yeah.
Yes.
Thank you. So I'm going to present a quick case study on the implementation of GAD65 testing at VGH, which was an example of how medical and operations work collaboratively together. So just a bit of a background, GAD65 refers to glutamic acid decarboxylase 65. High levels of antibodies against GAD65 are associated with autoimmune disorders such as epilepsy and stiff person syndrome, and non-neurological conditions such as diabetes type 1. Up until October of 2025, this test was sent out of province to in-common labs in Ontario. Samples from all over BCH are sent to VGH, batched and sent on dry ice via FedEx to Ontario. And then when the results do come back from in-common labs, they were actually back entered into our LIS. So quite a bit of manual entry and work in the PPA department of VGH. In 2024, VGH decided to repatriate some of the autoimmune testing in-house for a few reasons. One was to save money and provide results in our Cerner and LIS faster for faster turnaround time and reduce manual entry in the PPA department. Also to reduce workload on physicians who are required to complete the out-of-province applications. So a lot of the times we would get a test with no application, and that would delay patient testing. In this spring of this year, in consultation with the autoimmune department, medical, and our biochemistry department, hematology autoimmune began validating GAD65. And so the validation plan was developed with medical and included some things such as number of samples to run, precision, accuracy, those kind of factors. The validation data was generated by operations and medically reviewed prior to sign off. Operations and medical also work collaboratively on deciding the reporting criteria and the required LIS validation. The final considerations that went into this test were a go live date. So we had to consider medical availability. Our LIS readiness was LIS signed off, reagents and supplies. So operations a lot of the time has to make sure that we stop ordering reagents on our old tests or bring in new testing for reagents. And communication, how are we going to let the province or our clinicians know that we were running GAD65 in-house? So that was done in consultation with medical. And we also had to update our test information system on the VCH website, as well as let the other health authorities update their websites. And post-go live follow-up. So because GAD65 is a new in-house test to us, we sometimes get physician inquiries. So we're just continuing to monitor how many inquiries we're getting from clinicians on our testing. All right. We'll stop sharing, and it's back to Brenda for the final portion.
Thanks, Jen. So thanks, Jen and Luca. Real examples of how the dyad partnership works, in our acute care settings. But what I wanted to show that the dyads actually extend beyond local regional sites and into our provincial structures in BC. So provincial laboratory medicine services, kind of who and what are we? Well, formed due to the Lab Services Act of 2015. So provincial laboratory medicine services, or PLMS, oversees and strategically coordinates provincial laboratory systems, so working with all the health authorities to make sure we're all in alignment with provincial priorities. Now, these provincial priorities can come from Ministry of Health, they can come from our advisory committees, they can be brought by different health organizations. we're the kind of enabler and integrator for these provincial priorities. We also manage some delegated functions. We manage the Master Laboratory Service Agreement, which is a tripartite agreement between Ministry of Health, PHSA, and Life Labs. So we manage that agreement. And then, as Mike mentioned, I have operational oversight of laboratory services for Lower Mainland health organizations. So we have the people part of that organization. So we are a provincial entity. And I just wanted to show that within our structure, I do have Dr. Steve Loken, who is an anatomic pathologist, is my dyad that I work with. And I do work with Heather and Mike and all the different health authorities, but do work within our programs throughout the province, that we carry this dyad structure through our programs. So what I wanted to just show you is how that structure works, not only in acute care settings, but also in provincial programs. So in PLMS, we have our discipline advisory committees. These committees were formed to support PLMS in developing and implementing our mandate, which is to deliver high quality, clinically effective and sustainable laboratory diagnostics within the province. So you can see the 5 committees we have there, and you might say, where is transfusion medicine? Well, transfusion medicine actually sits under Provincial Blood Coordinating Office, which is one of the programs within PLMS that we'll get to later. But these committees were actually created on with a dyad structure. There is a medical discipline lead, and there is a strategic technical lead that lead these committees. The committees are formed of operational, medical, and technical experts from throughout the province. When these committees meet, we ask everyone to drop their health authority mandate and really think provincially. And you can see some of the work that is being done by these committees. So the medical leads report up through Steve, and the strategic leads report up through me. So this structure ensures that the discipline committee input flows into provincial strategic planning, operations, and provincial project governance. So that we do not want these committees to work in a silo. We always want to incorporate the work the committees are doing into provincial project governance, and how we can help get some of these initiatives moving throughout the province. So as I mentioned, we also have Provincial Blood Coordinating Office. So post-Creever inquiry, every province was to develop a Provincial Blood Coordinating Office. So it coordinates provincial programs and initiatives that actually promote effective blood and blood product utilization. So the PBCO works with Ministry of Health, with leadership, and we coordinate the blood-related issues and activities throughout the province. The PBCO medical lead, again, reports to Steve, and the operational lead reports up through me. And then Steve and I corroborate everything that's going to give it that real provincial insight. We have these transferred, we call it laboratory services. So when the Laboratory Services Act came in, Ministry of Health transferred 11 functions over to, at that time it was BC's Agency for Pathology and Lab Medicine, which is now PLMS. And some of these functions are guidelines and protocols. That's GPAC. The guidelines and protocols is the GPAC. Guidelines and protocols, requisitions. Every requisition must come through PLMS to get approved into Ministry of Health. Referring practitioners is the actual schedule of ordering practice. So midwives can order certain tests, podiatrists can order certain tests, and that those practitioner schedules are managed through PLMS, through this laboratory services group. Fee for service, what that is, the test review committee, lies within PLMS facilities, all facilities approval, and the out of country, out of province. So by having a function like out of country, out of province approvals through PLMS, we're ensuring that all these requests align with clinical evidence, provincial precedents, equity, and appropriateness. So we, through again, the dyad that's working together, reports up through Steve and myself for those services. The Alliance Management Office, that is the group that is managing the relationship of all private service providers under the Laboratory Service Agreement in this province. Right now, Life Labs has a master lab services agreement. Right now, Dynacare Valley Medical does not, but working towards one with Ministry of Health, and then we manage that contract. And any changes to their operations must come through the Alliance Management Office. They get reviewed by Dr. Loken and myself, and then go on to the ministry for final approval if it's going to change the contract in some way. And then provincial initiatives. What are we working on provincial initiatives, and where the dyad comes into effect also? So health, human resources planning. We got new pathways to practice for technologists in this province. We have a digital anatomic pathology strategy that was led by Dr. Loken and our team. And this is amazing. We are trying to bring in digital pathology in the province together. And what we did is we built reference architecture. This is a whole talk unto itself. But again, it was bringing in that medical and operational together to create the strategy, to create working groups. The working groups are medical and operational in all our working groups. Another thing we're working on is point of care testing, and the new service delivery modalities are like outside of our acute care facilities. Things, of course, like pharmacies developing point of care, and how can ministries still control that pathway, but not impact our acute care work and the medical staff and operational staff of our acute care sites. We're supporting the 10-year Cancer Action Plan, HPV, and looking at a provincial CAR T cellular therapy laboratory, bringing in pediatric cellular therapy with adult cellular therapy. Electronic laboratory test order requisition. Again, PLMS as the enabler brings in Doctors of BC, Ministry of Health, health authorities, and the Digital Health Initiative to work together to create provincial initiatives and solutions, quite frankly. So we've heard, what is a dyad? We got some real great insight from Luca and Jen on how it actually works for us in operations, and just some key considerations. And I don't want to talk a lot about them because I think Jen and Luca mentioned them too, right? Role clarity, delineation. No ambiguity. We don't want duplicated work. We really want to work together as a solid unit, right? We need to align leadership styles. Dyad partners, they have to collaborate effectively, communicate frequently, and maintain trust between each other, right? The time availability of our medical leaders. We know our medical directors often have clinical duties across multiple sites. So we've got to ensure that consistent engagement. And for our medical staff, we will hunt you down. We will find you and ensure our collaboration is always there with you. So the governance and accountability, right? We need to have that clear operating model so our teams know who to go with for direction. Decision-making speed. We have to be able and confident that we don't always need both parts of the dyad. And that comes back to the role clarity, definition, to trust and leadership, right? And that we do have variability across different sites and different disciplines, and multi-site organizations, which our health authorities are. It's sometimes a struggle to maintain the routines necessary to keep the dyad working. Cultural adoption. I think within lab medicine, we are well ahead of many other modalities within healthcare, programs within healthcare, where this leadership model of dyads has been embraced by lab medicine, and for a while. This is not a new concept to us in laboratory medicine. The key success factors I see are these four: respect and trust, mutual respect and trust for each other, the open communication channels, the complementary skill sets. We need to appreciate each other's skill sets. Leadership alignment. We have to be aligned together in the goals that we, and patient outcomes. And I think we are in lab medicine. So a successful dyad partnership, what it really requires, and it's the word intentional. It's intentional cultivation of all of these interdependent factors that create that leadership culture that values both perspectives equally. And we both bring that. And I have not seen in my many years of lab medicine where it didn't work well, where that mutual respect is there. And I believe it is through that intentional cultivation. So if I could leave you with a final thought on the dyad leadership model, right? It in medical laboratory, the clinical quality, operational performance, strategic alignment, that's the basis for it. But we need to really intentionally, clearly define communications. It really creates this balanced, accountable, patient-focused leadership structure that our staff believe in. When our leadership come together and we bring on new challenges and we're seen there together in agreement, the staff will follow us. But it relies heavily on clarity, collaboration, and I want to say intentional collaboration, and that consistent engagement. So we have to work together on a true dyad. Just some of the resources that I did use and years of experience, and leave it open for any questions. So I just want to thank you for allowing us to be here today and to talk to you.
Thanks very much, Brenda and Luca and Jen. Really appreciate you coming. As I was listening to the presentation, I was sort of thinking about what I would say regarding, this sort of work and collaboration and cooperation. I think your penultimate slide talking about the key factor success, I think it's really important for us to understand, we work cooperatively and collaboratively together, and understanding each other's roles and responsibilities is very important. So we work and create an environment that is supportive. I'm happy to open it up to questions from individuals. This is key because as you're training, the residents that are here, you sort of have this understanding of if you need something done, you ask so-and-so. But very important to understand that for, let's say, an anatomic pathology, if there's a technologist assisting you, that's great, they're assisting you, but you can't just tell them, go do this, go do that. I mean, they report through a different reporting structure, and they're there to work cooperatively with you, and they're not your minion, right? So, that's just a day-to-day. And I think what Brenda was saying, with respect to the structure, there's a site structure, like a local structure, but also a provincial structure. And you have to understand how things fit within those structures. Anyways, questions or comments?
Hi there, I would have one, if that's okay with you.
Of course, absolutely.
So I'm Marie Christine. I am pediatric pathology fellow in the Children and Women's, and I'm from Quebec. So I was curious to hear about you talking about your digital pathology initiative because they tried that as a pilot project in Montreal and CHUM. And I mean, from what I understood, now they are struggling just to get it funded, right? Because they were not expecting the huge volume of data and the financial issues, right, this creates. But now that the whole department has got accustomed to this, like, because from what I heard, like they were just going to put a stop to it, but everybody was there like, oh my God, are we going back to like glass slides? And they were like terrified. So I just, if you had like an input on how is it going for you guys, and if you have any insight for this.
Oh, it's going well. However, and we did create a business case. So we ran pilot, and what we did is we got support from Innovates BC so that the different health authorities could help them get the scanners, etc. And we built a reference architecture. And in this province, we have 7 different lab information systems. So we built this reference architecture above it. So the pull down of the slides would be in different areas. We had Northern Health working with cancer and them sharing slides. We had Vancouver Coastal looking at AI and how that would work. And so we have all these different projects within the province. We even brought in hematology to look at some slides and see how their slides worked within it. So then we've created a business case for the province to everybody go in together. And now we have 11.3 billion or 0.6, depending on who you listen to, deficit. So you know where we are. We didn't all convert. We have a second year of the project going on. We got more funding from Innovate BC. We're starting to work and creating the structure that lives provincially. So if different health authorities, because this is something foundations get interested in and things like that, but we want all health authorities to work within this provincial structure and to keep it going. And we are getting buy-in. So we had to go to Leadership Council, which is the CEOs of the province, Lab Advisory Council, which is all the VPs in the province. So we've really tried to work with and keep it provincially. So it is great. And what a time to present a business case when a budget is when the provincial budget is 11. So we've gotten more funding we're getting really innovative in our funding and how we can still work together as a province.
And
Yeah, and you
Marie
know what?
Christine,
Yeah.
oh, go ahead. Go ahead.
No, I was about to say, one difference I sort of see, okay, money is always missing, that's life. But apart from that, I'm thinking your model seems to be a little more like as was all your presentation about, right? That operations and clinical is together in this. You guys are together in like, okay, we have different like library systems to put together. Okay, but this is important for this. So, which I think we did not have. So maybe that's what's gonna get you there. So I'm just glad to hear that insight.
Thanks.
And Marie Christine, you're absolutely correct. Funding is always an issue. I mean, that goes across the country right now, especially the current financial constraints. But I think you also make a good point that one thing I've realized in taking over the role recently is just ask for help, because it's incredible what assistance you can get, the expertise that people possess, and the knowledge. it's very important to reach out as with respect to the digital, the different sort of information systems, et cetera, getting them to talk to each other, but also just, it was mentioned by Jen, the GAD 56, GAD 65 implementation. I guess I'm getting dyslexic. GAD 65 implementation, again, it's, from a medical perspective, we understand what the test is used for, but as far as implementing it and then trying to get the funding for it, that's something that we're just not educated on, and the support from the operations is just fantastic. Tyler does mention great presentation, and he's questioning the BCIT has increased MLT training spots recently. Is this meeting demand?
Not really, no. It's not meeting our demand. I know CNC is looking at increasing training spot, and Okanagan College is looking to create MLT program. We just heard that. So we may get there. Right now, we are looking at internationally trained, and we're trying that route, especially some American MLTs do want to come up, and they're trained very similar to us. So we are looking that route too.
And a comment by Lise Matsky in the, if I'm pronouncing the name correctly, again, the provincial versus a siloed approach, which I think is important.
And Lise was the big leader on that digital pathology.
Oh, there you go.
Any questions? She was that operational lead with Steve. So I didn't realize Lise was on. I would have just handed it over to her.
There you go.
Oh, that's all good. You got it.
Okay. Seeing and hearing no other questions. Again, thank you, all three of you. I really appreciate the presentation. Extremely important topic, as I say, very important to understand how we work together in a dyad operations system, and the support that we get from operations is absolutely incredible. So thank you very much.
The support from you guys is too. We need to do this together.
Exactly. Thank you. Thank you. Bye, guys.
Thank you.